Hi, this is Kori Hudson from MedStar Health Sports Medicine. Together with Matt Sedgley and the rest of our running medicine group, I'd like to welcome you to our introductory talk on event medicine, specifically with a focus on race medicine. We recognize that many of the volunteers who come to us to volunteer at races and other events do not come from a sports medicine background, and we think that's part of what makes our team special. We're excited to have medical professionals and other volunteers from many walks of life, whether that's physical therapy, whether that's podiatry, whether that's administration and other healthcare sector. We're excited to have you here. We want to go through this presentation to walk you through some of our race day algorithms. It's important to know that when we approach the collapsed runner or collapsed athlete at any event, there are a couple easy steps to remember. The first thing we do is the initial evaluation. We're going to check responsiveness and evaluate vital signs. And the first thing this is actually making sure that our athlete has a pulse, right? We do a quick pulse check. We see if they're awake, alert. We're making sure that they are breathing, right? And if they're conscious, we're going to have them sit down or lie down, and we may even elevate their legs while we complete the rest of their assessment. We'll get a QR code as we get close to the event that give you access to all of our race day algorithms. And those algorithms flow very similar to the CPR or ACLS algorithms that many of us are familiar with. And this is the master triage algorithm, and we're going to come back to that several times today. It's okay if you can't read all of the fine print here because we're going to talk through it. But the first one says we're going to assess responsiveness. And if they're unresponsive, we want to see if they have a pulse and adequate respirations. If they don't have a pulse or adequate respirations, we're going to go to what we call the emergency cardiac care algorithm. And this is the standard CPR algorithm that we're all familiar with, right? So emergency cardiac care, separate algorithm. We want to do a rapid assessment, open the airway, assess for breathing. You can assess for a pulse, but honestly, if you aren't sure if there's a pulse, we want you to start CPR. Put your hands together in the middle of the sternum, start pushing hard and fast, doing chest compressions at a rate of 100 to 120 beats per minute. We want you to call for help, get 911 or our emergency services on the way. In many of our races, we're going to have ambulances positioned at the finish line at the start in many places along the course. We want you to get those emergency help on the way and get the nearest AED on its way to you. We want to go ahead and get that defibrillator attached to the patient as soon as it arrives, have it analyze, and deliver that shock if it's advised. Get back on the chest and start doing CPR as quickly as possible. Back to our master algorithm, right? So if that downed athlete is unresponsive but does have a pulse, they are breathing, right? Now we want to ask the question of, do they have altered mental status? And altered mental status means a lot of different things to a lot of different people. But let's start with the fact that they just don't look right. They're confused. Maybe they can't tell you their name. Maybe they don't know where they are. Well, the next thing we're going to do is we're going to have someone start getting vital signs, check a blood pressure, check a pulse. But at the same time, with that set of vital signs, we want to check their temperature. Because in races, one of the things we worry about most is hyperthermia or elevated body temperature. And so we're going to look to see if they're too hot or too cold or just right. It's like Goldilocks. Are they too hot or too cold or just right? And in short, if they're hot, we're going to cool them down. If they're cold, we're going to warm them up. And if they're just right, we're going to look for other things that might be making them confused. So let's start with too hot first. So this is the hyperthermia algorithm. And in short, if their temperature is over 104 or 40 degrees C and they're confused, that meets the definition for exertional hyperthermia. And they don't just have to be confused, really any neurologic deficit. So that could be a seizure, that could be confusion, that could be something that looks like a stroke. That meets the definition for exertional hyperthermia, and we want to cool them down. In this case, this may seem strange to those of us coming from a hospital background. We don't care for the moment what the rest of their vital signs are. We don't want to get an IV in first. It doesn't matter if they're hypotensive. We don't care what their labs look like. The most critical thing is that we get them cooled down, because the longer their temperature is over 104, or really 105 is what the data shows us, the more likely they are to suffer multisystem organ failure. The data tells us that if their temperature is over 105 Fahrenheit for more than 30 minutes, their risk of multisystem organ failure or death goes up significantly. So it's our job to get that temperature down in less than 30 minutes, which means we don't have time to send them to the hospital first. We don't have time to do those other things first. We need to get their temperature down. And so we're going to do that generally by ice water submersion. So at the tents, the finish line tents, the tents near the finish line, we're going to have a method for you to cool that patient down, usually in small tubs that have 10-pound bags of ice, big bottles of water. We're going to submerge them in ice water. There may be some cooling pods. We'll talk through the specifics for the kind of race at the race you are. If you don't have cooling pods, if you don't have tubs, we can do ice packs to the groin and axilla while you're calling your race command and asking for the next steps. It's important to recognize that core temperatures are really critical here. It's important that we check a rectal temperature, and there will be thermometers available for you on the course so that we can do this. We want to make sure we give our athletes a modicum of privacy. So we have privacy screens, we have blankets, we use same-gendered teams when most appropriate. We want to do this as quickly as possible. We want to make sure we're cooling before we transport, because if we take the time to call the ambulance and we put them in the ambulance and we transport them to the hospital and they go through the triage process, every minute that they are above 104, 105 degrees Fahrenheit, we are increasing that risk of morbidity and mortality. And again, if they're slow to cool down, we're going to start looking for other causes for what may be causing their hypothermia. But really, that's a higher order time. Cool first, transport second. Think about hypothermia in our patients who are confused or having neurologic dysfunction. Hypothermia. It may seem unusual in a race to have hypothermia, but our race season starts early, and we certainly see some races where we'll have some sub-freezing temperatures. You add a little bit of precipitation to that, some wind, and we'll have some athletes who come in hypothermic. If their temperature is profoundly below normal, and you'll see the temperatures listed on your algorithm, we want to make sure we're taking our time to actively rewarm them. That may be as simple as getting them out of their cold, wet clothes. That may be getting them to a warm place, putting them under a warming blanket, getting them into one of our warming centers, and sometimes we need to actually get them to the hospital for some more active rewarming. We take our time to do this. We want to make sure we're not jostling the athlete too much, because there is a risk of cardiac arrhythmia if we take someone who is profoundly hypothermic and move them too aggressively. Back to our master triage algorithm. So we've confirmed that our athlete is breathing adequately and has an adequate pulse. They are not in cardiac arrest. We've made sure that they're not too hot and not too cold. But they're still confused. They've collapsed. So what's next on our algorithm? So exercise-associated collapse is a very common occurrence in races. It often happens right at the finish, where our athlete who's been running aggressively for a 10-miler or a half marathon or a marathon all of a sudden stops at the finish line, and all of their blood pools in their feet, and all of a sudden they don't have enough circulation and blood pressure circulating to their head, and so they suffer a syncopal event. The first thing we do for these athletes is we put them supine and we raise their feet above their head. Say, if they're pale, raise their tail. We raise their feet above their head, and generally these athletes improve in just a few minutes. We reassess their vital signs, and if their mental status improves, and they improve quite quickly, generally they can go home. They actually recover quite quickly, and we're able to get them home. If they don't recover quickly, then we need to start looking for another cause of their abnormal mental status. For our adaptive athletes, specifically our wheelchair-using athletes and our athletes with spinal cord injuries, we need to think about when they have an exercise-associated collapse, it may not look like collapse. Again, if they're strapped into their wheelchair, their racing chair, they may not have the same sort of loss of postural tone. They may not actually look like they collapse, or they may look like they've collapsed because they've actually crashed their wheelchair. So we need to have some increased level of awareness of what this looks like. We need to be looking carefully at vital signs, remembering that autonomic dysreflexia is something that can be absolutely life-threatening in our spinal cord injured athletes. Checking blood pressure, and if the blood pressure is elevated, have a high index of suspicion for autonomic dysreflexia, which can be caused by irritants. So we want to look for tight clothing, tight straps around the lower extremities. We want to be thinking about things like clamped urinary catheters and many other things that are actually listed here. There's an algorithm we follow, but quickly we want to try to lower the blood pressure. In many of our cases, we do not carry these medications in our finish line tents, so we'll be quickly looking to EMS and working to transfer these patients to the hospital. It is important, however, that when we make these transfers, we let EMS and the receiving hospital know that autonomic dysreflexia is on the differential diagnosis, because this may not be something that automatically comes to mind of the receiving emergency physician. So again, with the adaptive athletes, the wheelchair using athletes with spinal cord injury, let's keep this in our mind when we see the collapsed athlete or the athlete with altered mental status. In the athlete with altered mental status, adaptive and able-bodied athletes alike, we want to think about hyponatremia, athletes who drink a lot of free water while on the course, especially those athletes who are out on the race course for more than 4 hours. Those who are heavy sweaters may lose more salt than they take in, and they may actually aggressively and acutely drive their sodium levels down below 130, in fact, below 125. That may lead to altered mental status. In our races, we generally try to adjust for this with oral salt intake in patients who are awake enough to be able to take oral fluids, whether that's by electrolyte beverage, by salty bouillon, by salty chips, or something similar. The key here in diagnosing this, if we don't have a sodium analyzer at the finish, which in many races we do not, will be, again, the athlete who's been on the course for quite some time. These tend to be women more than men. Again, they've been on the course for a long time. They may actually have salt caked on their lips, salt caked on their clothing, and they may in fact look puffy. Their rings may be too snug on their fingers and their toes and their feet may look swollen. And you can ask them, were they drinking electrolyte beverage on the course or were they drinking free water? One thing we notice with healthcare providers who are not used to providing care on the course is that our hospital tendencies lead us to want to give IV fluids, which is something we generally don't need to do on the race course. One, because most of our athletes are actually fairly well hydrated. Most of our athletes have been trained to drink well while on the course. Most of our race courses have plenty of fluids and beverages available, both free water and electrolyte beverages alike. And so very few of our athletes actually arrive to us in our first aid tents and finish line tents hypovolemic. And so IV fluids are very rarely the right solution in the finish line tents. And though it is often the first answer we have when we're in the emergency department or in the operating room or on the hospital floor, when we see somebody who's hypotensive or who looks ill, that's very rarely our first answer when we're on the race tent. So think hard about what else might be going on before going to IV fluids, because again, our sodium balance may be different. And we might actually do more harm than good by reflexively giving IV fluids on the race course. Exercise-associated muscle cramps are something we see a great deal, and we're very fortunate that at most of our races we have a number of athletic trainers and physical therapists and other volunteers who are often there to help our athletes with some of their musculoskeletal needs, including cramps. One of the things we want to do when we see athletes who are cramping is really encourage them to keep moving. If they stop at the end of the race, if they sit down and start cramping up, the more they sit still, the more they're going to cramp up. So if we can encourage them to keep moving, if we can encourage them to keep stretching, the better they're going to feel in the long run. If we can help them with some stretching, if we can help them with some gentle massage, if we can help them with some ice bags that'll help with some massage, that'll often help break that spasm a little bit quicker. And don't forget some of the other basic medical conditions which can happen anytime. Anaphylaxis may happen associated with bee stings or medication or food allergies. If you see somebody who looks like they're having an acute allergic reaction, including shortness of breath or hives or acute GI symptoms or other associated allergic symptoms, recognize that an epinephrine autoinjector is the first line treatment. We want to ask if the patient has their own. If not, we want to use one that we have or one that comes from EMS. After giving that epinephrine autoinjector, if we need to, if their oxygen saturations are less than 93%, we want to give some supplemental oxygen. If they're wheezing, we could consider an albuterol nebulizer treatment, but we want to be moving that patient towards the hospital with EMS sooner rather than later. But the key is getting that epinephrine auto-injector if there are 2 or more symptoms associated with anaphylaxis. When we see those patients with altered mental status, we want to be thinking about hypoglycemia as well. We have a number of athletes who participate in our races who are diabetic and who may be running with an insulin pump, or who may be running while on their usual oral or injectable hypoglycemic agents. The first thing I like to do when I see these patients, or any patient who comes into the tent, is quickly check for a continuous glucose monitor or check for an insulin pump. If they have a CGM and can show me what their glucoses have been over the course of the race, I like to see what the trend has been. If they have an insulin pump and they're awake enough, I ask them to suspend it while we're doing the assessment. Or if they're unconscious or unresponsive, I like to turn it off or take it off of them while we're doing our assessment and getting a blood sugar. Because if the patient's unresponsive, the last thing we want is for them to continue to get insulin and be hypoglycemic, and we're just making the situation worse. So again, just be on the lookout for diabetic athletes who may be getting worse, not better, in front of you. Recognize that there are some differential diagnoses that may be associated with different finish times, especially in a marathon. Our faster runners, those who come in less than 3 hours and 30 minutes, we're more likely to see things like exercise-associated muscle cramps, heat illness, exercise-associated collapse. Between 3:30 and 4:30, again, we see cramps, heat. We may see some hypothermia. We'll see some exercise-associated collapse. We'll start seeing some blisters. And more than 4.5 hours, we'll start seeing some hypothermia on those cold days, people who've been out on the course a little bit longer. We'll see less exercise-associated collapse. Again, we see in people at a slower pace. They may be walking a little bit through the rest stops. But at more than 4.5 hours is when we start seeing the hyponatremia. We may start seeing some blisters, and we'll start seeing some athletes with overuse injuries as well. So depending on where you are on the course and whether you're in the finish line tent, recognize that the type of illness you'll see, the type of injuries you see, may vary based on where we are in the day. It's important to think about when it's okay to send people home and when it's okay to send them to the hospital. Know that you've always got support. Your medical director for your race will always be available, and you should always run these decisions by them if you have any question. One, we use an electronic medical record. We want to make sure before we send anybody home that the information is correct, that we've got their correct name, their correct date of birth, their bib number. If for some reason the person that we're talking about was a spectator or a family member and was not a runner or an athlete, we want to make sure that we've created an encounter number for that spectator or family member as well. We want to make sure that we recommend follow-up, right? That none of these incidents is an isolated incident, that no matter how minor it seems, that we give them the what-if situation, just like an ER visit or an urgent care. Even if it's just a blister or a scrape on the knee, we want to tell them that if it looks like it's getting infected, if they have any concerns, they should follow up with somebody when they get home. If they're local, we can certainly give them our own system phone numbers for when and how to follow up. If patients have been sweaty, if they've been wet, if we put them in one of our cold tubs, if it's been raining, if it's at all possible, we want to make sure we're sending them home in dry clothes. We want to reunite them with their own belongings, if at all possible, so that we can get them back into their own dry clothes. We want to get them their own cell phone, their own wallet, their own belongings, so that they're able to contact their family. And we do want to discharge them into the hands of a responsible person. So reuniting them with their family and friends is really important, so that we have given these instructions not just to the patient who was ill or injured, but also to somebody else who can express understanding for us. So again, for most of these patients, we want to make sure that before they go that they are able to eat and drink, that they're not vomiting, they're tolerating oral fluids. We want to make sure that they've got a normal temperature. Again, for those altered mental status patients in particular, we want to make sure they're not hot, they're not cold. We want to make sure that they've got a normal mental status, and we want to make sure that they're walking on their own power, right? We want to make sure that once we send them out of the tent, they're not going to collapse just outside the tent for their own good, and because it's a bad look for us if we discharge them. If they can't meet any of these we can give them one road test, and if it's only been a few minutes and they fail the first road test, we can take them back to a cot, take them back to a chair, and give them a few more minutes to try to rally. But if after 20, 30 minutes or after a couple of road tests they're still not passing, we probably need to think about transferring them to the emergency department for a bit more extensive workup. And that's it. We'll have a QR code available for each race that will go through the emergency action plan specific for your race. That will have the contact information for your medical director and the other providers who will be covering your race. It will also have the maps and the information for each of the aid stations and each of the tents along the course. That QR code will also inform you what aid supplies will be available for your event, what medical supplies you should have, what medical supplies you should bring, what you should wear, and what you should have available for you on the day of your event. If you have any questions, please don't ever hesitate to reach out. Your medical director for the event should be your first point of contact, but if you ever have any questions, don't hesitate to reach out to me, Dr. Kori Hudson, or to Dr. Matt Sedgley. We are always available to answer any questions, and we are looking forward to seeing you on race day or the day of any one of our events. Thanks so much, and thank you again for volunteering at one of our events with MedStar Health and MedStar Sports Medicine. Have a great day.